Hi, welcome everyone. So just to kind of get started, we're going to review some of our 2-year data from the BRIDGE Registry, as you heard. And hopefully I can advance this. Here we go. Okay. So there are several phases to the study of the BEAR implant. Of course, the earliest phase with Martha Murray and her group was the BEAR-1 feasibility trial. And many of you are familiar with this data. There was 0% re-tear at 2 years. And those patients have been followed out through 6-year visits at this point. BEAR-2 was a randomized controlled trial comparing to hamstrings, and the re-tear rate at 2 years was just shy of 14%. Also with 6-year data ongoing, not inferior to hamstring reconstruction. And then BEAR-3 was a prospective study looking to sort of look at age as a potential risk factor for re-injury over time. And that is an ongoing prospective study within the sort of similar constructs of the other phases, sticking to the original technique as described for the BEAR. Time from injury to surgery, all those constructs that are somewhat, conforming to the original definition of the procedure. BEAR-Moon is an NIH study comparing BTB to BEAR, ongoing. So we look forward to the results of that. And what we're, of course, here to talk about today is the results of the BRIDGE Registry, which is essentially a real-world look at utilization of the BEAR. Sometimes these surgeries are done more than 45 days out from injury. We have a broader age range, as I'll show you soon. We've enrolled 300 subjects, so we have completed enrollment for the BRIDGE Registry. And some of the data we're presenting on tonight is really the results of our first 100 subjects having achieved 2-year follow-up. And within this group, we're seeing a 5% re-tear rate, so lower than some of those previous numbers, but also with some modifications, as you will hear about tonight. A little slow to advance. Let's see here. Oh, gosh. Worked well when we practice it. Okay, so as I stated, the goal of this registry is to look at outcomes and how our patients are doing, reoperation rates, re-tears, PROs with unrestricted indications, meaning surgeons are using their own indications. And here we go. So currently 300 enrolled, 235 subjects have reached 1 year, 177 subjects have reached 2 years. These are all the sites where these subjects were enrolled from. Because we need to sort of make a data cut or a time point to pull data and analyze it, we've been looking at the first 100 subjects. So we looked at them at 1 year, and at 1 year we had no re-tears, for instance. And then this data here we're presenting to you is the 2-year data analysis. Within this group of 100 subjects, 5 subjects did exit early, although 2 of them were at 9 months, so close to that 1-year mark. And early on in this enrollment, we did capture some subjects, when they were already post-operative, but say coming back for their first post-operative visit at the time that a site had come on board. So some of these were enrolled during their early post-operative timeframe and then followed prospectively. And then going forward beyond these first 100 subjects, subjects were more enrolled prior to surgery rather than shortly after surgery. Here you can see the distribution of where the subjects came from for the first 100, fairly evenly distributed from the first 6 sites that were on board. And then we have, obviously more sites on board now that we included to get to the 300 subjects. So this is the age distribution. You can see that 2/3 of these subjects are female. Interestingly, we do have a fairly large segment of the population that is under 18. A full quarter of the subjects are under 18. The overwhelming majority of these subjects are between the age of 18 and 39, and then also a group over the age of 40. Most of these are tears that are mid-substance or proximal, very small number, just one of these that was a distal tear. Now, one of the things that really differentiates this data set, again, is not having to be necessarily restricted to some of those requirements of the earlier studies. So our mean time from injury to surgery was 46 days, but some of those were done much farther out. You can see our maximum time was 154 days. So that would be a case where you're looking in the knee and you find that the tissue quality or stump is really high quality, and a surgeon decided to proceed with the BEAR despite it obviously being more than 45 days out. Also, looking at the ranges, if you look at the age, I do want to point out, you can see that the minimum age enrolled was a 7-year-old, and the oldest was 70. So while there are a number of people over the age of 40, again, we have 25% of this group that are under the age of 18, with some more extreme ages, including in the younger direction as well. So looking at the first 100 subjects at 2 years, the re-tear rate in this cohort is 5%. Again, at 1 year, there was no 0% re-tear rate. And then some of these tears occurred, as we approached 2 years. So if we specifically look at the 18 or younger population, that re-tear rate is 8%. And that would be 2 subjects. One, you can see here, 15-year-old re-tore during return to play, was playing hockey at 23 months, a 17-year-old playing basketball at 14 months. When we look at the 19 and older age group, the re-tear rate is 4%. And again, you can see a smattering of those few patients there. You can see those are at 19 months, 29 months, 24 months, and these are all with some high-risk sports. So when you look at what surgical technique was used, and Dr. Brady is going to go into this, interestingly, 4 of the 5 re-tears had the original classic surgical technique, utilizing vicryl suture in the stump, ethibond bridging suture, buttons. And, we're going to go into some of this. It's interesting that in the real world scenario, we are seeing quite a number of variations on the technique used, although the purpose of this registry was not necessarily to determine if the modified techniques were superior to the original technique. The overall reoperation rate does include a couple of contralateral tears. You can see the overall reoperation rate is 21% in this cohort. Some of these are for meniscus injuries without ACL tears. And some of the additional surgeries are some things that we're seeing less and less of over time. A couple of manipulations under anesthesia, probably related to some of the earlier PT protocols that were more restrictive as compared to the more advanced protocols currently being used. And then some removal of suture, mostly ethibond suture within the notch, which we are seeing less of as well going forward. This is the physical examination, not available in all 100 subjects, but this was completed at 1 year. And you'll see that the majority of these Lachmans are essentially fairly normal, 80% between 0 and 2 millimeters, 20% between 3 and 5 millimeters, with 94% of them having a firm endpoint. And looking at pivot shift, these are almost all negative, 90%, 8% with a grade 1, and very low number with a residual high-grade pivot shift. And then looking at the PROs, the mean IKDC at 2 years is 87, mark score is 7.2, return to sport index 70.4, really good KOOS pain and function scores, and also for KOOS function sports and rec 88. So Dr. Brady is going to go through some imaging and illustrations of this, but just by the numbers, if you look at the variations in surgical technique within our first 100 subjects, the variations that we were seeing were that rather than using vicryl for the stump suture, 16% were using a high tensile strength suture in the stump. Similarly, for the bridging sutures through the BEAR implant, 39 out of the 100 used a high strength suture rather than ethibond. We saw variations in the stump suturing technique, Bonnell versus luggage tag. And then in terms of fixation on the femur, we started to see anchor fixation over button in the femur, and as well in the tibia, anchor fixation over button. In this cohort, this first 100, you see that still button is used more commonly than anchor, but you'll see here as we look at the technique modifications in the full 300, there is somewhat of an increased use in the number of anchors in the femur and definitely an increased use in the number of anchors in the tibia. Additionally, increased utilization of high strength suture in the stump and high strength suture in the bridging the BEAR implant. So we're seeing definitely a shift towards greater utilization of high strength suture. Looking at age distributions, I just wanted to show you where we're headed. Since our analysis of the data is based on the first 100, it does appear that the whole group is reflective of similar distributions. If you look at these bar graphs here, you can see, again, we do have some, probably about a quarter of the patients in that younger age group. And again, just I would say fairly similar distribution. So I'm expecting to see fairly similar results as we get to the full 300. All right, so I'm going to shift to Dr. Brady, who's going to share some more detail of some of these modified surgical techniques.
Thank you so much. Thanks everybody for tuning in. I'm going to see if I can advance the slide here. There we go. So we alluded to this, but the instructions for use or indications for use in the FDA approval have been updated with FDA approval for an adjustment from the 50-day cutoff that you might have noticed if you adopted this technology early to a more tissue quality focused indication, and then inclusive of partial thickness tears. And so with this, I think the modification of the technique becomes sort of a useful set of tools in your toolbox. As a reminder, the classic technique is to put a Bunnell type suture, vicryl suture, number 2, in the torn ACL and redirect that to a button on the femur, which is loaded with 2 doubled over strands of Ethibond. Let me just see if this will advance for me. That become 4 strands that you then take through a tibial tunnel. And the original instruction was put your tunnels in front of your footprint and expect your Ethibond to break over time as you regain flexion. And you can see how this becomes sort of a suture management mastery course. But you can see the illustration there. So this is the classic technique. You take the knee into extension to fix your construct. You have dual button fixation. And I put tension in quotes there because you're bringing the ACL back to its origin and bringing it up into the BEAR. Okay, so modifications. The one that I think we're all not super suspicious makes a huge difference is an anchor in the tibia versus a button. I think fixation in the tibia, as long as we trust an anchor, as long as we trust a button, we can't prove this yet, but we're not as keen to drill down any differences there. That's a pretty simple adjustment. And so if you trust an anchor, I think it's fair game to use an anchor versus a button. Sorry about the delay. There we go. The other modification that starts to sort of catch our eye is the type of repair suture, the technique of placing it, and the material used. So many are using these suture materials with a loop at one end and creating luggage tag type constructs. You can do that with an absorbable suture or a high strength suture. The departure from the Bunnell technique allows you to capture, for instance, 2 bundles. If you have 2 separate bundles torn or a partial tear, then you can capture 2 different parts of the ACL independently and direct those to the same origin. And so it gives you a little bit more flexibility. And then the bracing suture, you can switch to a high strength bracing suture that you don't expect to break. You could do 2 strands or 4 strands. You could do a tape type suture versus a high strength non-absorbable suture. And then you can modify to an anchor on the femur. And the reason that I think this might matter a little bit more than an anchor on the tibia is that it changes the position of the knee when you fix your ACL. And so I'll show at the end the adjustable loop fixation to the femur. I think if you're going to fix to the femur under direct visualization, as a surgeon, I find that very satisfying to see my ACL look like an ACL again. But it also changes the way that it interacts with the BEAR because the BEAR is going to go in secondarily. So we're keen to study these differences if we can parse them out. And then there's that tensionable suture button construct. I think one of the attractive factors here is that you can retension your ACL repair once the BEAR is inserted and pull it up into the BEAR in the same way that you would in the original technique. And the problem with analyzing this data, and the reason that I'm not reporting back that one thing is better than another in sort of pure groups of patients, is that if we combine these, it gets to be muddy waters. And if you modify the technique, then we're starting to think about things like, well, if you don't expect your bracing suture to break, then should you put it centrally in the footprint? And that becomes very nuanced and detailed. But I think we're all very encouraged to see this data that the failure rate remains low, very reassuringly low, even as our group starts to explore these different techniques. And that really allows people to be sort of industry agnostic with their BEAR implant and use what they're comfortable using. And then I'll turn it over to Dr. Strickland to lead us through some cases here.
But anyway,
Gotcha.
so this first case is Dr. Wittstein's case, and we just tried to pick some different kind of patients, and I'll certainly have her weigh in, so don't mute, because who knows if you'll be able to unmute. But 31-year-old wrestling coach and physical therapist, interestingly, you'll see my case in a minute, is the father of a physical therapist. And I think sometimes physical therapists are extra interested in adopting to new techniques. It was a former D1 wrestler. He'd injured his knee sparring with an athlete. It was a contact injury with a heavyweight wrestler falling onto his knee with an acute pop and swelling, a 2B Logman, a pivot glide with a large effusion. I mean, pretty standard story for an ACL. Here you can see x-rays look perfectly normal, and the MRI. And I think one thing that's worth talking about, and we really haven't talked about it yet, is, and it's something that my residents will comment on, is that, if I look at this MRI, it certainly looks like a proximal tear, but you don't see the best signal in the stump. And when you see something like this, and just as a rule, I always, when I book a BEAR, I always say, well, possible, and I make sure the patient knows what their second choice is. And I haven't actually had to pivot. The one time I pivoted, I really told the patient I thought it was quite unlikely that I would do a BEAR. So if anything, I just didn't pivot to the BEAR. But here you can see a complete ACL tear, but just a lot of high signal in the stump. But here on arthroscopy, you can see it's a femoral sided avulsion. You see really good tissue, and essentially that's what you want to see, especially if you haven't done a lot of these. I think this is less scary than when you see what Jackie described, two bundles, one cyclops forward, although there's different ways to address that. Here you can see a notchplasty. When I remember still my first case, when they're describing, you do this kidney bean shaped notchplasty, you're really just getting some bleeding bone anterior to the footprint. And they were always very specific to not take away tissue within the footprint. I know some people use an osteotome to just get a little bit, kind of shave away a little bit of bone there. I personally use a shaver. And then here is using ACL guide. I think you meant outside in, not inside out, which I just assuming from the guide. And again, you can drill the pin however you'd like. I typically just use a spade tip guide wire. You can do it any way you'd like. And at this point, Jocelyn, are you always using these luggage tag type sutures?
Well, these are the fiber rings, these like basically these are like they're like baby luggage tags that you can then load onto a tensionable suture loop. One thing I do like about this technique is that you can, unlike the anchors where you have to kind of tension and fix inflection, I like this that you can tension it, but then you can retension it in extension. You can look at your button go up, you can tension it, and then even after you've gone fully into an extension and placed your BEAR, you could even, tension it a little bit more. I don't always use this technique, but I do like this technique a lot. And I was just going to comment what you said about the appearance of the ACL on MRI. I think there's so many times that the fibers look sort of ghosted, but there is that linearity to it. And those are the ones where you end up looking in there and the ACL you would feel badly about removing. But
Right.
the more you look at these, I think I've gotten better and better at recognizing which ones are gonna have that appearance when I get in there, and it's sort of that grayed out, but like full length ACL that tends to have actually like this appearance, even though I used to see that image and think, well, that looks terrible. But now, you know, the more you look for it, the more you start to see it. And so anyhow.
Pretty. And here's the loading of the suture for the continuous loop. Here you can see better that it's not just a luggage tag because you see that loop. And here it's ready for the button and the passage to tension the rings. Personally, there we go. This is a button deep to the IT band. I guess you just took your scope in there. I started out tying over a regular endo button. I pretty quickly switched to an adjustable loop button just because I didn't like making that lateral incision. It just seemed futzier to me. And also my surgical team appreciated that I was doing it more similarly to a standard ACL.
Yeah.
It just caused them less confusion.
Yeah, that picture is, I just like to look through my little perk incision and I just look at the button and I see that it's deep to the IT band, but flush on the cortex. So before I tension it. Mm-hmm.
That's great. I think one of the things that made me switch from a standard tie over button technique was that I don't typically do an outside in femoral tunnel. And so I had to balance my arthrotomy to insert the BEAR with my desire to do a medial portal way medial to get the trajectory I wanted and not have the button be around the back. And so that's a consideration too if you're picking your technique.
Yeah, so for me, I use an outside in guide and I do all of my ACL reconstructions, well, at least my soft tissue ones, a quadruple or a quad auto, all inside. So this was a completely natural transition to,
Right.
you know, using BEAR because it's basically like doing an all inside ACL, except for you're not dunking a graft. And so,
Right.
yeah, I think if you're used to outside in drilling, it's a very easy, you know, thing to adapt to. You're just shifting it somewhat anterior. So, yeah. And so this is the image with those fiber rings tensioned to that button, which we saw deep to the IT band, and then that button was loaded with the this bracing suture, which is used then for the to go through the BEAR.
And so in that past image, you can see that the ACL is up to the footprint, that it's, you know, there's tension, you can stick your probe in and you haven't put your BEAR in yet. So this was the exam at 3 months. You can see range of motion is good, but not perfect. As mentioned already, like since these patients move a little bit less the first few weeks, although a lot more than in the initial protocol, it's not uncommon to see a little bit less motion. Although at 3 months, I think this looks pretty good as far as range of motion. In effusion, you can see it was just a trace, essentially rock solid Lockman. And then 4 months post-op, range of motion was symmetric, no effusion. If you get to the privilege of having surgery at Duke, I'm so impressed. You get this isokinetic or biodex testing. So really 100% hamstrings, which is awesome. And extension strength was 89%.
I do think this person having so much knowledge of rehab obviously is rocking his rehab, but and he speaks to that in a little bit in a quote I gave you, but knowledge, preparation, and not having a graft.
So it's interesting because I'll share the quote in a minute about my patient, but he said, as a PT, I've rehabbed post-op ACLs with various graft types. Not having a graft site helped me avoid some of the early phase challenges he sees in some of his patients, like delayed knee flexion with quad harvest and hamstring weakness or irritation with hamstring autograft. Prehab and a good understanding of the rehab protocol was a key to my success, which is awesome. This slide's a little out of order. This was before the other ones, but I would just put in a couple slides. So I work with my husband, so all our numbers are kind of doubled. Actually, these numbers are a little bit higher now, but we had a total of 73 of these. 58 of the 73 were a twisting type injury, basketball, soccer, a lot of skiers, and then a lot of a huge range of other types of sports. We had basically a third had meniscal repairs, 6 had mastectomies, so about 10%, 7 chondroplasty, 10%. And we did add a LET, and we'll talk about that also potentially in the Q&A aspect of these. This patient is 56. He had one fall in his 2023 ski season. It happened to result in this ACL tear. He said the snow was heavy and wet. Ski dug in, really a classic story. But he said he really wasn't in that much pain, had some pretty minor swelling. He had a 47-year history of skiing, so he'd been skiing the vast majority of his life. But the MRI did reveal a torn ACL. His son was a physical therapist, was familiar with BEAR, but his surgery was at 56 days. And part of the reason that it was delayed, and this was in the period where we were told that it needed to be done within 50 days, is because he really didn't think the injury was so significant at the beginning. As you know, we kind of talked about like this MRI, you can see a really, really good stump. You get a sense that there's going to be really good quality tissue, but it's not always the case. So on evaluation, the first thing I do is look at the stump on MRI, and then once you get in there, you can always reassess. This was that kidney-shaped lesion. Here's the spade tip passing the sutures. Now, just a note, because we've talked about technique, we've all kind of, or most of us have changed what sutures we're using, both for the bracing type knee spanning suture, as well as what kind of suture we're putting in the stump. I now use an active braid suture, which is a high strength suture, but has some collagen in it. I think some people are using, I think it's sort of dealer's choice, but the vast majority of us are using high strength suture. Also, as far as passing, we have, for some reason, different equipment at our surgery center versus our main hospital, even though it's both HSS. So I use a disposable, like first pass at the main hospital, and then I use a knee scorpion, or actually a shoulder scorpion, because the knee scorpion is a little bit small to pass my sutures. Here was back when I used Vicryl, and you can use a fiber loop, you can use a nitinol wire, it really doesn't matter. Again, we have different things at different places. Here it's a flip cutter, but you're just not flipping it. I think there's lots of options.
I think sorry to interrupt. I think it's worth mentioning that that ring type guide on the tibial side is really nice to help keep the tibial side from being injured as you make your tibial tunnel, if you're going to creep up into the footprint a little bit. And I think right, exactly. It sort of minimizes the injury. And then you made a really good point about what type of suture passer to use. I would not use the same one you would use for like a root repair, because it's just too much tissue. It's too big a suture to pass. It'll get stuck. Your needle will break. And ask us how we know it runs into trouble. So use something robust that can pass a really strong suture.
Yeah,
I use the same type guide on the tibia for these.
It helps, especially if there's a cyclops, you can kind of push the whole thing back.
Right.
And as far as the order of events, I just gave you my order, kind of deal with the femur, pass my sutures, then I passed my tibia. I started doing it with a different order, and things were getting all tangled, and I don't like tangled sutures. So, and then I've never looked down at the cortex. I love your picture. I typically get a quick fluoro shot just to make sure, but
I just hate wearing lead.
Good for you.
And I also like, to see when you're tensioning it to make sure it's just not going back down in the hole. So
no, I totally agree. Here, this looks like a massive incision. The actual incision maybe looks like a double portal. It's really, really quite small. This is just enlarged, and I'm using the scope to take this picture, but you can see basically down into the notch. In reality, it's that I can get my finger down into the notch to push that graft down. And you can see bringing the stump up to the wall. I talked about the type of suture. Soaking, we haven't talked too much about this. This isn't a whole webinar on the technique, but I typically ask the anesthesiologist to start drawing blood right about when I'm asking for the guide for the tibia. every once in a while, it's only happened to me once, the anesthesiologist for some reason cannot get blood. And so we have just taken a jam sheeting needle and taken some like blood from the distal femur. It's probably the same. The studies were all done with peripheral blood, but I kind of think blood is blood. So that's just sometimes faster. Then make sure you don't get the saturated too much. This picture, which is a Miach picture, shows it like all fully saturated. In reality, I leave the distal aspect of the implant a little bit firm, so that I have something to push on. Otherwise, it would be like push on mush. It would fall apart too much.
We ran into that here with the IV fluid shortage. We were running patients pretty dry. And they couldn't get a blood draw. And so I turned to the tibia knowing that you had done that case, and it worked really well. It's a nice way to get blood if you're just having trouble with your IV access.
Yeah, I think in some cases it just might be a whole lot faster. I typically, because I haven't used an anchor on the femur, I just tension my sutures in full extension. And I stopped using a button on the tibia a long time ago just because sometimes they'd feel the knots, and I'm used to use an interference type anchor on the tibia. I think it's maybe a little bit easier and they're less likely to feel it. So this is his quote. I love that it was less intrusive. The recovery process was appealing because he wouldn't have to rehab. It's sort of exactly what the physical therapist said, but he also said, when I was going through rehab, there were 4 other ACL reconstruction patients doing rehab alongside me. 2 of them were doing great. One was really struggling. And then when he compared himself, what he was able to do week after week, and at 3 months post-surgery compared to the reconstruction patients, he did have a significant difference in his progress, was able to do jumping and more strenuous activities by the 6-month mark. And I love these stories, and I don't get people telling me this all the time, but he said by the end of rehab, his BEAR implant was stronger than it was pre-surgery, that knee, but he actually discovered a new passion for structured gym activities. And I do hear that, here and there, if somebody really has a great experience with physical therapy. But it was nice that he got to compare himself to some other patients doing the same thing. I don't routinely get post-operative MRIs. You can see this was the uninjured knee, but this is the normal knee. So some patients just have a little bit higher signal in their native ACL. Here you can see the BEAR at 9 months with good tissue. Here is a 6-month post-op MRI of one of my patients, where you can see a really good sort of alignment of the tibia under the femur, as well as a good looking graft. This is Jackie's patient. Somehow in New York, we didn't have an IV fluid shortage. I think, I don't know how, but we heard about it and they warned we were going to have it, but I think we just banked more IV fluid because we have so much room to store things here. So Jackie can tell the story more, but 21-year-old male, motor vehicle accident, arthroscopic cases were getting canceled. It was complicated by a contralateral tibial shaft fracture. And so, in a normal patient, we're going to talk about why he's not normal in a second, you might have just left this alone and waited till you had some IV fluid, except he also had a posterior lateral corner. So
yes, right. And a distal one to boot. And so I wanted to get that tissue restored. So if I was going after the posterior lateral corner and this is a metal suppressed MRI because it was a bilateral knee MRI. So I apologize for the graininess, but you can see it's a proximal tear there. And I felt like I had little to lose because we were going to be there anyway. And this was the case that pushed me to try a femoral anchor, because without having to tie over a button and pass the suture, I felt like I could save some time with the arthroscopic fluid running. And so he was a pretty significant case in my practice.
And then here we'll get through, again, you see a good stump using luggage tag suture lengths. The drill for the anchor, it's a little hard to see, but you can see kind of a similar, you can see it, I think, much better here with a knotless anchor, bringing that stump up nicely to the femur. And here you can see the post-op with the buttons related to the BEAR, as well as the posterior lateral corner. And here you can see.
And he's healing well. He has been very stable. I was a little bit worried about his ability to do the rehab with the other leg being out of commission as well, but I think he proved us wrong. He's young and fit and managing really well.
That looks awesome. And we're gonna skip this one because I want to get to questions. And so I think maybe everybody can unmute and we'll see what questions there are out there.
Yes, I invite everyone to put in their questions in the Q&A function, but we did have some outside questions come in that I'll stage right now. Has being involved in the registry and seeing this data in real time changed the way you discuss BEAR with your patients? And has it led to any technique changes? I think you guys talked about that, but has your indications changed by being part of the registry study?
I can go first. I think that initially when I started using this technique, I was certainly like indicating people who were, more low risk, like a 45-year-old skier with a femoral wall kind of peel off, like classic example. And then over time, I have had more patients and parents of younger patients requesting this as an option. And because of the results that we are seeing in our younger patients included in the registry, I am offering that to younger patients. I think with more confidence. My caveat about younger patients is, aside from like the quality of their tissue, I think there's another important factor with younger patients is they have to not be, they really have to be compliant. And I think some teenagers are very impulsive or younger kids, especially if they're not having much pain. I think it's not like the ability of this technique to work. I think there's more like some of my my one BEAR I've ever had to revise was just a young kid who had really poorly controlled ADHD and very impulsively, went and did a layup at like 3 months post-op, which maybe a reconstruction wouldn't have survived either. But in general, like I've started to think, I am indicating more, younger athletic patients. And one of the, holy grails, I think, of ACL surgery and reconstruction surgery is, we still haven't solved what, post-traumatic arthritis. And just anecdotally, like these knees are very happy and not inflamed over time. And, some of the animal data, of course, suggested there may be less post-traumatic arthritis with this technique as compared to reconstruction. But, I think that there is a lot of promise in this technique that we maybe don't even, know yet. But that's a long-winded answer. But I think people are interested in this, especially when I have a parent of a teenager who's asking, like, is my child's ACL, a candidate for this? I'm more likely to consider that now based on the results that we're seeing.
Yeah, I agree. I think the shared experience has really helped, especially when I was early in adopting this technology. It was wonderful to be able to speak with the other members of the registry and sort of monitor the data and understand a bigger N and sort of where people are pushing the envelope. I wanted to do the original technique for a while because I just was a rule follower and I didn't want to be the first one on the block. But I think I've told you guys that out of my first 4 BEAR patients, 2 of them fell within 4 weeks of surgery. And so I very quickly thought to myself, nope, I think I would like to hermetically seal you with the strongest thing that I can get off the shelf. And so I think having that shared experience and increasing my own N in the early period, it was really helpful to understand where I could push and what I could do if something didn't work the first time and things like that.
What about LET? I don't know if either of you have done that in combination with.
I just did that like 2 hours ago. So this is interesting. As I was running home to get on this webinar, the patient I had today, she really wanted a BEAR with an LET. I mean, people are very educated in reading about these things. So they're very interested in, potential proprioceptive benefits, like not having to have a graft, like, but they're also reading about the stabilizing benefits of an LET. So that's what this patient wanted. And she's one of the patients I said, I'm not sure about your tissue. Like, like you said, Sabrina, always possible, but what is the graft that you're okay with if we need to use a graft? And anyway, so today I ended up doing a BEAR with an LET. So.
And did you tension the LET first and then what
Yeah.
order? And then put the BEAR in?
Yeah, because right, because there's some flexion when you're tensioning the LET, and then so I prepped everything. I had this was a fiber ring BEAR, so I had those all passed, pulled up the button down, the tibial dunking suture ready to go. And then went ahead and secured the LET and then loaded the BEAR and brought it into extension.
Yeah, I also have a young person, 16-year-old, who failed early. And I think maybe the impulse control was at play there a little bit too, because she started to jump with PT and somehow translated that to playing volleyball in rapid succession and landed from a jump and blew it. And I don't know. I don't know if a reconstruction would have held up any better, but if I could go back, I would have added an LET to that BEAR. I haven't done it yet, but I think if I meet another teenager who wants it, especially if it's a young woman with a hyperextensile knee, I think if the data is supporting it for reconstruction, it makes a lot of sense to add it to BEAR.
Yeah, I agree with you.
A question is, any chance this also improves meniscal repair healing in concomitant cases?
That's a great question. It's being studied right now, as you might imagine, with the fibrin clot technique that was described to improve outcomes. People are studying the BEAR, I believe, for meniscus repair as a sort of separate line of study. I would not be surprised to see that data come out. We have not proven it to be true yet, though.
I mean, I would say clearly not all of the BEAR implant stays in the notch. So, there is some degree of this circulating around the knee. I mean, I've never specifically put any next to the meniscal repair, but it'll be interesting to see what they show. I'd love to see, I would love to see an animal study on that because I accept animals heal everything.
We have
Good
another
point.
outside question that I like to pose to the panel. Why do you feel there may be such a large discrepancy in the re-tear rates that were described in the BEAR 2 study versus what we are seeing currently in the registry study?
Well, one of the obvious differences is technique modifications. Personally, I would guess that amongst the modifications, the ones that are probably making the largest differences are use of high tensile suture in the stump and the higher tensile bridging suture, I would guess. Some of the difference is population type. Obviously, those were all very young patients in the BEAR 2 study. But even in our 2-year data with at least this first group of 100 with the patients under the age of 18, it was an 8% re-tear rate, so not as high.
Is anyone injecting TXA, which inhibits plasmin in the joint, or seeing any benefit to that? I haven't injected, I'll answer and then get, but I haven't injected into the joint. I have we give it IV.
I haven't employed it for anything other than bleeding control in osteotomies, but I know a lot of people are using it. Dr. Wittstein, what are you doing?
Yeah, the funny thing is, I had never used TXA, but I used it today. This is my day of things we're talking about. Not on an ACL patient, just on I do think it's being used more and more in sports. I think some people are using these with ACL surgeries. Certainly, there's data on using it in rotator cuff repairs and improving outcomes. I haven't used it with a BEAR or ACL reconstruction. I did use it today on a TTO with an MPFL on someone who on the contralateral side I could have sworn had von Willebrand's disease. She bled so much, so I used TXA today when I did her
Mhm.
second side. But yeah, it's not something I'm routinely using, but I think it's becoming more and more prominent in orthopedic surgery. I know, like obviously arthroplasty people use it like quite a lot, but I think it's certainly creeping into sports medicine.
Is there any data on using the BEAR with PRP instead of whole blood? I believe Dr. Murray studied this early on. She tried PRP in isolation, and she tried a collagen scaffold in isolation. And I think she might have tried PRP versus whole blood, but I know that it was on her mind, and it was in sort of the early period where she was trying to figure out how best to capture and hold that fibrin clot. So she chose bovine collagen because of its platelet adherence properties. And then I don't know the nitty-gritty of why whole blood versus PRP, but it certainly reduced costs and reduces the time that you need to take.
Right, and that's, I mean, another reason I haven't even considered it, just because patients do get charged for that because we can't recoup that, and so generally we don't want to make this more expensive, and especially we don't have any data for it.
I think this is a different line of thinking, but there's some data on injection of PRP versus injection of whole blood for other problems, and whole blood seems to be non-inferior in those studies. And so I think that makes a lot of sense.
We have another outside question. Based on the panel's experience, where is a great or who is a great patient to start with if you're new to your BEAR journey?
The easiest, most perfect patient to use for your first BEAR is a skier with a femoral sided avulsion.
Agree. It's one bundle most of the time. They don't have a pressing need to get back to their sport in 4 more months because their season is once a year. I agree wholeheartedly.
Yeah, and a lot of those patients, that's certainly how I started. They're willing to wait, and generally are a little bit lower demand. I mean, I've certainly seen that in higher level recreational skiers, but a lot of times you get the story, well, it's my first time skiing in 10 years, and yeah, they're much more willing to slow down for a while.
Yeah, skiers are like the gateway patient to
I agree.
BEAR.
I agree.
And then you kind of see how they do and like get their muscle back and their knees are quiet and you know,
Mhm.
like seems, this is good.
Very
But yeah,
reassuring.
I think it's like analogous to like who's your first reverse shoulder you should do? Like a plain old cuff tear arthropathy. Like who's your first BEAR you should do? Like do a femoral side avulsion skiing
Mhm.
injury. That's a good way to start. Yeah. Nice long stump, tissue to work with,
Right.
amenable patients. I totally agree.
Mhm.
Another outside question to the panel. What is your experience with partial tears and mid-substance tears, and is there any pearls while using the BEAR implant in those tear patterns?
I think universally, I would recommend that if you're not looking at a very straightforward femoral avulsion, just take your time assessing the ACL tear. Because a lot of times you'll go in and initially think that you're not looking at much remnant and then find it folded sort of forward under your camera or stuck to the PCL or something like that. And so I would have a freer elevator handy. I would take your time, gently retract. Don't start shaving too quickly because you might catch the edge of that thing and do some harm. But I think if you take your time and bring it together, and if it's stuck to PCL, mobilize it, which takes a little bit of time. You don't want to beat it up. And so you just really have to coax it and sort of elevate and elevate and elevate. I don't know if you guys have anything to add to that.
Yeah, I mean, so often some of the fibers are stuck down to the PCL, even if it's not very chronic. And yeah, I'll use
Right.
an elevator or the trocar sometimes from
That's a
the
good one.
scope, just as like a little bit wider of a blunt tool to sort of like peel it off. And then you're right, sometimes there'll be like a bundle flipped to the front that is just can be incorporated in the sutures.
Mhm.
Yeah, I do spend a little bit more time now, like being like, I think I used to be more quick to be like, oh, this isn't good for a bear, we're going to reconstruct. And I almost did that today in this patient that wanted the bear with the LAT. At first I looked at it, I said, oh no, we're just going to reconstruct. And then I was like, well, hold on, let me poke around here. And I peeled off the PCL, and before long I was like, actually there's plenty of tissue. So,
Mhm.
And
I think you start to look at them differently.
And I think the same sort of applies to a partial. I mean, generally, I feel like partials are either functional and I'm not really doing the surgery because I see some continuity there and their Lockman is good, or it's incompetent. And then I get in there and I'm like, well, wait a minute, it looks like there are some posterior fibers. And then that's kind of perfect for a bear because you would have felt bad taking those down, or but then let's say the anterior medial bundle is cyclops forward, you can tack that back, and I think you feel better about the whole procedure than if you took the whole thing down.
Yeah, one nuance too is the passing of the suture. If you have two bundles and there's a piece that's flipped anteriorly and you're trying to bring it back, you want to pass your suture from front to back to minimize the chance that it's going to rip through. Actually, Bo Fraser, who I think is on the call, is the rep who works with me and brought that technique to me, and I'm very grateful because I think it's really more likely to preserve the frayed edge if you're going from the displaced fragment to the fragment that's still there.
And I also think sometimes, and again, they're all a little bit different, but some of these more luggage tags or cerclaging type sutures can kind of bring bundles together, sometimes a little bit differently than like a Benel style sutures. Because you can sort of just grab them and then pass, and it's like almost like cerclaged together, which is nice.
So one question is, how do you assess plastic deformation and quality of tissue sufficient to proceed with BEAR versus bailing out for a reconstruction? And which autograft do you prefer if you have to convert to reconstruction? I'll answer it first, but I don't really worry about plastic deformation because I feel like you're putting sutures in the stump and you're pulling it up sort of as much as you can. So at least I don't worry about that. If the sutures aren't holding, or you're sort of peeling it away and it's just shredding, kind of, that would be a case where I wouldn't be particularly excited about doing a BEAR. And which graft, I mean, I would say for the 50-year-old skier, I just plan on using an allograft. So I would use the same as I would use in that patient otherwise. And in the 18-year-old, I'd use a hamstring or a quad. I tend to like hamstrings a little better than quads, but that's just my own preference.
Same here. I would let the athlete or the patient decide. I use all three grafts, and I think there are reasons for each one, and it's nice to have all the options available.
Yeah, I think the tissue quality, does suture pull through? Do you have, is the tissue just adequate? I care more about that than the concept of plastic deformation because you are retensioning it. And then the grafts that I most commonly use are either a quadrupled semitendinosus or a quadriceps autograft. But yeah, certainly I do entertain the option of allografts in older patients that are in less high demand sports as well. And yeah, like you, Jackie, I like to have the conversation. I'm not like super prescriptive about exactly which graft for a patient, but I think sometimes patients have preferences, and if they're reasonable, then that's fine by me as well.
Yeah.
I mean, I think this is a really good question. When comparing my teenage female BEAR patients with my teenage males at 6 to 8, 9 months post-op, the knees just seem a little looser, but our data doesn't show that. And so have you noticed that? Have you got?
Sorry, when you're looking at your female versus male patients at
6 to 9 months post-op. So I think part of the data not showing this is that in the first 100 patients, many of them were retrospectively grabbed as the registry study started. And so the comparative contralateral knee exam wasn't always there. So it's hard to know in people who had a 3 to 5 millimeter Lockman whether that was their baseline or not. And I don't think you can rule it out. I definitely think that young flexible joints become young flexible joints post-op as well, and I certainly see that difference side to side. And I would speculate that that would probably be the same with a reconstruction. I haven't noticed that it's looser than reconstruction per se, but I'd love to see that with a bigger N than just my own cohort.
Yeah, I mean, in that register group, there was bilateral Lockmans on 75 of them at 1 year for comparison. Bilateral.
Okay.
Yeah.
That wasn't showing up.
And I don't know if either of you remember the BEAR-3 data well enough as far as, you know, patients being a little bit looser. I mean, BEAR-2 certainly wasn't looser. Our data, I mean, because they have instrumented knee laxity, and BEAR-2 and BEAR-3 we do not.
That's true. It's a little bit subjective with the Lockman. We're not doing a KT 1000 measurement in the registry. I think just not everybody has that technology.
Yeah, that's true.
But it brings up that question of LET, you know, if you've got a little bit of a loose post-op result. I think that's where the stability trial started with all this line of questioning. And I think BEAR might not be an exception, you know, I think that warrants some more study.